Good morning, and welcome back to our second day of our first ever Montana Pain Initiative Conference. I hope you enjoyed yesterday as much as I did. I have seen many of those presentations before, and every time I seem to get new information out of them. Just a very interesting issue that we're working on, and today is exciting for me because, you know, we've done all of this work to do assessing, and today's where we actually get to start looking about where we are moving forward, what's happening right now in Montana. You know, our first speaker will be talking about overall in what's going on in the nation and on how we're institutionalizing some of these practices and giving us some good food for thought. Then we'll take a short break and we'll have a physicians panel discussion. And we'll get to hear firsthand from some Montana physicians, you know, the uniqueness of their practices and some of the challenges they've been facing, and some also creative solutions that they might have come up with. Then we'll be hearing from Ann Corley right before lunch. She's going to share with us what the Missouri Pain Initiative has been up to, and I think that'll be a very interesting conversation and presentation as well, so we can learn how one pain initiative has been very strategic in their approach to improving pain in their state. And then after lunch, we'll have a networking lunch, and after lunch, we'll have Dr. Borganick talk to us about our new Montana Pain Initiative. We're wanting to formally launch that today, and then break off into work groups, and you'll get to self-identify which work group that you want to be a part of to kind of take us to that next level of what are going to be our priorities for our Montana Pain Initiative. And you know, for this conference, I know a lot of us are here to learn how we can improve, but I really encourage you to stick with us for the whole conference. It'll be really tempting to duck out at lunchtime, but if we're truly going to put what we've been learning about this conference into action, we really do need to take those next steps of self-identifying with the Montana Pain Initiative and trying to move forward. So I really encourage you to stick with us for the whole conference. Our first speaker is Dr. June Dahl. June is a professor of pharmacology at the University of Wisconsin School of Medicine and Public Health. She received her PhD in physical chemistry and spent many years in basic research before turning full-time to educational and advocacy efforts to bring improvements in pain management. And I've had the opportunity to work with June over the last year, and she's an amazing teacher, and I'm honored to be one of her students. Please welcome June Dahl.
A quick announcement. June, if you'll excuse me for just a second. But on behalf of the task force, I wanted to present something to Kristen, because she's been really, we could not have done this
It's exciting to be here, and it's been exciting to watch the progress of the task force over the last many months. Really, your approach provides a model that other states in the U.S. could use to formulate this task force and then have it really carefully and slowly examine the issues in the state and come to recommendations for you to consider today. I wish to acknowledge the American Cancer Society, because I think without them, this really wouldn't be happening, and to acknowledge, as has just been the case, Kristen's participation. She's been phenomenal. It's been a joy to be able to work with her and also with Lindsay, and so I compliment you folks for all of the things you've done. I think there must be two of Kristen's, I'm not sure.
Sorry, I forgot to do one thing.
Oh, okay, she isn't perfect either.
No, I'm not. Sorry about that.
That's okay. Now we're okay. We're all together again. I hope that by the end of the day, and I agree with Kristen, please don't sneak away, because this is your day. The planning committee will be very disappointed if you aren't energized and ready for action. And I'm certain they won't mind if you're just a little bit tired, because working in this arena is exhausting, putting your mind to how to deal with the complex issues that you face as you try to improve pain management. It's not easy business. Now, my objective is to spend this time we have together, and I better get my watch out so I pay attention to the time, reviewing my perceptions of the progress that's been made in the last, let's say 20 to 30 years, which really is the time during which I've had some engagement in this issue. And I think, as my title indicates, there is every reason to be optimistic about the future of pain care. And this meeting certainly gives great optimism. But at the same time, and for reasons that I will try to make clear, I think we also have to temper that optimism with a bit of caution, because there's special forces at play in this country right now which make obtaining our objective, which is to assure that everyone has adequate management of their pain, obtaining that objective more difficult. Well, let me go over some things that you know very well, because one of the challenges is I know that I'm speaking to the choir. You would not be here were you not. You don't need any convincing. On the other hand, perhaps it's essential to go over some very basic things, because as you go forth and affect your colleagues and the people in your community, you have to have some facts in hand. And some of these have already been alluded to, both by Dr. Twillman in his talk and in the white paper itself. You know that pain is a very common malady. It doesn't spare anybody. Although I once read, and maybe this is going to say something about my politics, that Richard Nixon had never had pain. But whatever, we know that in reality, pain is very common, and it does usually impair function, and it comes in a variety of forms. It can be acute due to injury or surgery or trauma. It can be chronic, and there are so many conditions that lead to persistent pain problems. And I will tend to do what the geriatricians did a few years ago. I will morph chronic into persistent, because I think persistent pain is a little less pejorative term than chronic pain. When we think about chronic pain patients, we think about whiners and complainers and drug seekers, et cetera, and we don't often put a positive spin on those folks as we should. But we've got lots of pain problems: migraines, lower back pain, various kinds of arthritis, a lot of neuropathies. So there's a sea of pain out there. Now, pain can be good. It certainly can serve as a warning sign that something is wrong in our bodies. And so it leads us to seek medical attention. That's good. But if it persists, it doesn't serve any useful purpose. I don't know anybody who has become a better person because they're experiencing long-term pain. And it has a lot of adverse physiological and psychological consequences. If you look at the results of the white paper and the patient survey results that you obtained for Montanans, you'll notice that a very high percentage of them told you how pain affects them. that it affects their family life. It affects their ability to work. It affects their ability to enjoy. So huge numbers of problems. And as you've heard over and over again, and the reason you're here, is that unfortunately pain is not well treated in many instances. And this applies to all kinds of pain. And again, I apologize for reviewing these things that you know, but as we look at advances in pain management, we have to recognize that one of the significant advances is our better understanding of the problem. Because if we have not identified the problem, we don't have the ability to mobilize, to energize people to really deal with something that is so pervasive as is pain. So all kinds of pain are inadequately treated. Now, if we look back in time, really we find that since the first demonstration of the effectiveness of ether as an anesthetic, and that was way back, something like 1847, even before I was born, that there has been a significant recognition and attention being paid to doing a better job of managing post-op pain. We have a lot of surgeries in this country. We have lots of data that show that more than half of people have unrelieved pain. If you work in an acute care setting, if you take care of people who have had surgery, you know that if their pain is not relieved, they can't breathe well, they can't cough, their bowels don't start working, and if you can't cough and pass gas, you can't get out of the hospital. We also have very good data that pain delays healing. This is a critical thing. So people don't get well as quickly as they do if their pain is effectively controlled. Surveys show, and you need to think about this as you plan for the future, that patients have more pain after discharge than they do when they're in the hospital. So this has to be a target for your consideration when you think about changing practices. The other critical thing that you have to bear in mind is that unrelieved pain has been documented to be a risk factor for the development, did I say chronic? Unrelieved acute pain has been documented to be a risk factor for the development of chronic pain problems. So the nervous system is not static, it's a dynamic entity. It undergoes change when it's constantly bombarded with noxious stimuli. And the mechanisms that give rise to these chronic pain problems when acute pain is not well managed are not understood, but the data are there. This is very, very real. So 50% of people have chronic pain after thoracotomy. And if we can manage that pain aggressively and effectively, then we can reduce the likelihood that chronic pain problems will arise. Now, cancer pain is a very common issue. Folks who have cancer, as you probably know, fear pain more than they fear death from the disease. And we have the data from a number of surveys that document the prevalence of pain in cancer, what causes pain in cancer, and also what percentage of people do not have adequate control of their pain. The numbers are staggering. And again, there are lots of reasons why this is true. We have to understand those reasons and address them very aggressively. Now, because I'm talking about advances, one of the things that I need to talk about is the advances that have been made in the treatment of cancer. And I want to call your attention to a paper that was just published in Pain Medicine, and I give the reference on the slide, and it is titled Chronic Pain in the Cancer Survivor, A New Frontier. And what it points out is that the landscape of cancer pain is shifting into a chronic pain situation, which blurs the distinction between persons with pain related to cancer and that challenging, persistent pain population. One of the goals of the American Cancer Society in the next decade is to make cancer into a chronic disease state in which long-term control is possible. And indeed, very significant advances have been made. Persons are living longer and longer with cancer, and therefore longer and longer with pain. And the Institute of Medicine published a report, From Cancer Patient to Cancer Survivor, lost in treatment. And here we're talking about folks getting lost in pain treatment because they don't fit neatly into one category or another. We have 10 million cancer survivors. We ought to really applaud that advance. 6 million of those are over the age of 65. Lots of them have pain. And that pain may not be addressed as aggressively as it would be if those folks had, in fact, cancer that was clearly there and showing in a variety of ways. So it gets into this whole question of why is it, in fact, that we don't always look upon those people who have persistent pain problems where there isn't a clear diagnosis or evidence? Why do we look at that kind of pain as not quite legitimate or not real? Indeed, it's very real. And that's a new issue we have to think about. You heard a lot about chronic, or as I call it, persistent non-cancer pain. The numbers are staggering, more than 100 million persons. 50 million are partially or totally disabled. Remember that most of those 100 million have a spouse or significant other who is also affected. So you have to double those numbers. One study that was done of families with chronic pain showed that the spouses were 2.5 times more likely to be depressed than were the persons who were experiencing the persistent pain. So we have to think more broadly about all of the persons who are affected, not just the person with the pain problem himself or herself. Folks have looked critically at the economic burden of pain. I have to be just very crude and say, sometimes it's hard for me to get across to people the critical importance of relieving patients' suffering, to be concerned about how they feel and how they enjoy their day. But one of the things that I always find true is that money talks, and people really do understand numbers, especially when they get big. There was a issue of the Journal of the American Medical Association published in November of 2003, and it was dedicated entirely to pain. And one of the articles was on the economic burden of pain. And the investigators specifically looked at headache, back pain, arthritis, other musculoskeletal problems. And they looked at lost productive time. And the numbers are huge, $61 billion a year. But the thing I want to emphasize to you is that those investigators found that most of the lost productivity, most of the economic burden wasn't because the people didn't go to work, but it was because they went to work and they didn't do as good a job. We have to think about both sides of the coin. And I think this is particularly an issue when one is thinking about workmen's compensation and those who are injured on the job. Getting them back quickly may not be the appropriate way, especially if they're still feeling a lot of pain. Well, why do we have such a problem? Why aren't we doing a better job? I mean, you folks in this room know how to manage pain. Why is it not being done as you know how to do it? Well, I think it's worthwhile looking back in history and getting some perspective on things. You know, 150 to 200 years ago, physicians viewed pain as a sign of a person's vitality. Well, is that a big surprise? After all, they were alive. And there weren't a lot that people could do, in fact, when faced with a lot of diseases. Surgeons often viewed pain as important to healing. And what's most important, I think, is, and maybe this persists today, and that is that there was a controversy about whether pain should be treated because surgeons thought it was critical to healing. And religious authorities questioned the morality of relieving the pain of childbirth. It was important for women to suffer through childbirth because that was the critical element in helping them to bond with their child. There is a lot of literature. I'm sorry for those of you who are men here, but I want to speak to the women. There is an amazing amount of literature about the attitudes of women and pain and giving women pain medicine. I mean, what kind of wild things would a woman do if she were anesthetized? She would probably act out all sorts of sexual fantasies. This is in the literature. I can't even believe these kinds of attitudes. Well, in the context of that, there were lots of good things going on, in addition to ether having been discovered. In 1806, morphine was isolated. The hypodermic needle and syringe came along in 1855, just in time for the Civil War. Finally, around the turn of the century, aspirin was introduced. But throughout the 1980s, opioids were standard treatment. And we're talking about opium and morphine. And way back in 1870, physicians began to express concerns about the morphine habit. And I ran across this fascinating word as I looked at the history, the word narcomania. This is indulgence inducing bodily and mental prostration and mental perversion. I don't know quite what these words mean, but that's what morphine did. And there was a conflict at that time, we're talking 1870, between physicians' desires to relieve pain and their fear of inducing addiction. Does that sound familiar? Does that sound familiar? And so way back then began the origins of our love-hate relationship with opioids. Let's face it, we do have that love-hate relationship. Well, World War II came along, and if we look again historically, wars have done a lot to advance medicine. A lot of wonderful things have been done in efforts to save those who were wounded on the battlefield, which have had an impact on the civilian population. So World War II presented an unprecedented opportunity to observe and work with complicated injuries. And one of those who worked with injured survivors of that war was John Benica, himself suffering from persistent pain. He wrestled to pay his way through medical school. And in so doing, he injured himself in ways that led to his having persistent pain. Well, when he looked at these survivors of World War II, he was baffled by their complex pain problems, and his experience with those servicemen, and they were mostly servicemen at that point in time, was the genesis for his 20-year campaign to establish multidisciplinary pain clinics. He understood that treating pain wasn't just about giving drugs, that there are a lot of other treatment modalities that need to be brought to bear if you were going to restore these veterans to really kind of a functional sort of life. In 1953, he wrote a seminal treatise, The Management of Pain, and a new version has been published not too recently. And then he went ahead and began to engage people throughout the world who were concerned about pain and founded the International Association for the Study of Pain in 1972. In that time frame, there were important things going on that were focused on cancer and on end-of-life care at two major centers. One was at Memorial Sloan Kettering Cancer Center in New York, and the other was in Great Britain, primarily led by Dame Cicely Saunders. Dame Saunders died just last year. She was a remarkable clinician. But at Memorial Sloan Kettering, between 1951 and 1971, that's a long time ago, before many of you were born, Ada Rogers and Ray Hood were involved in the quest to find this ideal analgesic. What would an ideal analgesic be? It would relieve severe pain, but it wouldn't cause addiction. And in the process of their really carefully done analgesic trials, they learned a lot about opioid analgesics. And by that time, there was more than morphine. so they could look at other drugs in the family, hydromorphone and methadone, for example. In that same time frame, Kathy Foley was involved in setting up a pain program at Memorial Sloan Kettering, and actually she formalized the pain service there in 1981. Now, Dame Cicely Saunders had been working really in that same time frame, and it was in 1967 that she founded St. Christopher's Hospice. And I think anybody who's in the hospice movement has heard of St. Christopher's. Such important observations emerged from that framework. And Dame Saunders talked about total pain, complete pain. So she was looking at all aspects of pain and focused her life really on providing exemplary care for the dying. She promoted the use of Brompton's cocktail. What was that? It was heroin and gin. What a great combination to relieve the suffering of people who were dying. But Robert Twycross, who came along after Dame Saunders, looked at this and really did the studies that showed that oral morphine given every 4 hours around the clock provided just as fine an analgesic effect as did Brompton's cocktail. I remember sitting at a dinner with one of the nurses from St. Christopher's, and she recalled the time when they switched their patients from Brompton's cocktail to oral morphine. At 2 o'clock, they all got Brompton's cocktail. At 4 o'clock or 6 o'clock, they got the equivalent oral morphine. The patients didn't know the difference. But it took lots of work on the part of Dr. Twycross to show what the relationship was in terms of doses. And what Twycross also did, and remember this is in persons with cancer, advanced cancer who were dying, is he showed that addiction and tolerance were just not issues. He didn't find those phenomena in that patient population. Now, in 1986, another seminal event occurred. The World Health Organization released cancer pain relief. And in the context of that, they introduced the analgesic ladder. Now, the ladder was great in its time. We all find some problems with it now, but remember that most of the countries of the world, and that is still the case today, unfortunately, don't have access to really effective analgesics. But this ladder provided them with a model for how to approach their patient population. Nothing could be done for folks in India who were diagnosed with cancer. There wasn't radiotherapy, there wasn't chemotherapy, but at the very least, the cancer unit of WHO decided that we needed to relieve their suffering, and we could do it. Now, I have to say, since you're talking about starting a Montana Pain Initiative, that it was in 1986 that the Wisconsin Cancer Pain Initiative was formed. And it was formed in response to legislation to legalize heroin. The Congress had considered a law to make heroin available. They were very frustrated because friends and loved ones were not getting adequate control of their pain. And they looked at St. Christopher's and other hospices in Great Britain and said, oh, if heroin were only available, no one would have to suffer from pain. But we recognize that heroin is an expensive and controversial way to give morphine. It's a prodrug. We also formed the Wisconsin Initiative because we recognized that we had a pain problem in our state. We had wonderful survey data of the type that you've gotten with patients in Montana that showed us what the prevalence of pain was and how significant the problem of undertreatment was. And we recognized there wasn't anything going on nationally. Nobody was paying any attention to pain. And we said, when we formed that initiative, that the problem wasn't due to the lack of effective therapies. We really could do a lot to manage pain at that point in time. But they weren't being used appropriately. Why? There's a huge gap between what was known and what was done. And we recognized that we had to address attitudes and behaviors, that things like traditional medical education didn't make any change, didn't do anything. Somehow or other, we had to do something to change attitudes. Now, I hope you figure that out today, how to change attitudes, because we still haven't figured that out. Education by itself does not change practice. Now, also, in the 90s, what happened was we had further documentation of the undertreatment. Now, we're talking about cancer pain, pain at the end of life. This raised awareness. It brought funding for pain and palliative care. These pieces of research, the data that they produced, got a lot of media attention. You must use the media. They are very powerful allies in anything you do to move forward, to deal with undertreatment of pain. Charlie Cleland, who was in Wisconsin at that time, published a study of patients in the Eastern Cooperative Oncology Group. These were patients who were being taken care of at first-rate cancer centers with great oncologists. He published his paper in the New England Journal of Medicine, and his data were sobering. Less than half of patients with metastatic cancer had adequate pain control. This was at our comprehensive cancer center and other comprehensive cancer centers in the eastern part of the United States. This was scandalous. And then Dr. Twillman's already mentioned the support study. The Robert Wood Johnson Foundation gave $22 million to try to change the way people died and looked at dying in hospitals, and published in December of 2005 in the Journal of American Medical Association, 40% of hospitalized patients had moderate to severe pain in the last few days of life. Again, something that got wide attention in the media. Now, what did these studies do? They did something very important. They led to critical funding from the Robert Wood Johnson Foundation, for one thing, because RWJ looked at that support study data and said, we gave $22 million and it didn't do anything. Let's give money to really make a difference. And they have poured lots of money into pain and palliative care. And then Soros, the billionaire who has lots of money to give, decided to use some of his funding to create the Project on Death in America. And Kathy Foley really created that idea, and she's been the director ever since. And Robert Wood Johnson also gave money to fund our project to put pain assessment and management into the Joint Commission standards. I convinced them that it was, one thing to give people carrots to help them learn, but you had to have some stick out there. You had to say, you've got to do this. And that was the origin of the standards. And even though they were supporting pain and palliative care, they understood that the bad habits start right at the beginning when patients are hospitalized and they have acute care problems. So bless them for giving that money. Now, RWJ and Soros have given $300 million, and lots of great things have happened. Projects EPIC to train physicians, ELNET to train nurses, CAPSI to help people develop palliative care programs. They've funded many fellows, stimulated development of many palliative care programs. It's wonderful how the palliative care program numbers have increased in this country. But who's going to fund things in the future? Because RWJ and Soros aren't going to put their money there anymore. The well has run dry. Well, we have the magnificent National Institutes of Health, don't we? Shouldn't they give a lot of money? Well, Dick Chapman, who's at the University of Utah, did a study, and he found that if you looked at the NIH budget, now he looked in 2003, I doubt it's any better now, that funding for pain represented 1% of the NIH budget. Now, if you think about the impact that pain has on citizens of the United States, it seems to me that it should merit more than 1% of the NIH budget. Now, during this time also, as we look at advances, important things happen. We had validation of pain assessment scales in adults and children. People could no longer say, we can't measure pain, it's too subjective. These scales were validated. Now, we still have challenges in the cognitively impaired. And of course, as our population ages, the challenge of dealing with pain in the cognitively impaired is going to increase. There is greater awareness of the impact of pain. I've given you some facts that tell you how much more we know about how bad pain is. And I think one of the messages that we have to tell everybody is pain is bad. It does not make you a better person to suffer. There are no data to support that. There's also important recognition of the multimodal therapy. What does that mean? It means that you can do a better job with fewer side effects if you combine therapies. And for example, if you treat post-op pain, you can use 40% less opioid in that post-op period to control pain if you give folks other kinds of meds, or if you do regional anesthesia and anesthesia. So this concept of multimodal therapy, combining drugs that work by different mechanisms of action, or combining drugs and non-drug therapies, is really a critically important advance in our understanding of managing pain. You don't do it with a single entity. And then we have a lot of important developments regarding drugs. New methods of drug delivery. We have extended release opioids. We have transdermal and transmucosal delivery systems. We have PCA pumps. We can give drugs epidurally and intrathecally, even intracerebroventricularly in very rare instances. The COX-2 inhibitors were introduced. You're going to say, hey, was that an advance? I thought these drugs were killing people because of their increase in morbidity and mortality. But if you give someone a COX-2 inhibitor before surgery, and you can do that because the drugs don't affect platelets as the older nonsteroidals do, here again you have data that show 40% less opioid is required. Why is opioid sparing good after surgery? Because people have lots of side effects. And if you don't need to use as much drug, the side effects aren't as significant. There's new developments for treating metastatic bone pain. There are now drugs that will cause remission of arthritis. Arthritis is a lot more than a pain problem. So we're getting at the causes of pain. And there are very significant advances in the management of neuropathic pain. I say 10, 15 years ago, I would have people come up to me at meetings and say, my mother died of postherpetic neuralgia. Why? Well, because nobody could do anything about it, and she just gave up. She stopped eating, and she willed herself to die. Or I've heard of other tragic circumstances where patients decided that they would drown themselves rather than endure this horrible shingles pain. Now we have ways to treat it. And also, in terms of getting at the cause of pain, we have a new vaccine for herpes zoster. So the idea is if we can get people to have an adequate titer against this virus, we can keep them from getting herpes, and we can then reduce the likelihood that they will get postherpetic neuralgia, this horrible shingles pain, that even with all the therapeutic armamentarium available is still not easy to treat. So we have lots of other advances. We have recognition by important groups of the importance of pain management. ONS was the first, the Oncology Nursing Society, was the first to publish a position statement on pain. ASCO, the oncology groups did. All sorts of other groups have, well. We have the release of numerous clinical practice guidelines, all sorts of practice guidelines. We have professional pain organizations. The American Society of Pain Management Nursing, AAP Medicine, AAP Management, the American Chronic Pain Management Group, American Pain Foundation, and the growth of state pain initiatives. So there's a lot of things going on out there. And whereas in the 1980s, when I was first working on pain, I never heard about a pain program, there isn't a week that goes by that I don't get some sort of monograph or ad or flyer that says, come to this pain meeting. Sometimes I feel I'm just being barraged by this. So there's an enormous difference. And we had these advances. Joint Commission introduced the standards. Now, I have to be honest with you, people are assessing pain. They're documenting the results of the assessment. We don't have any data that these standards have changed pain management practices, unfortunately. The Veterans Administration decided to focus on pain, and they created a fifth vital sign initiative. The Centers for Medicaid and Medicare Services launched quality improvement initiatives with all the states And every state in our nation did a QI project on acute pain and on chronic pain. Very significant advances. And as the last bullet point indicates, CMS has released a draft of some new intent statements, and I hope that what they will be doing is putting demands on facilities to document that they're doing a good job of assessing and managing pain in that population. Dr. Twillman mentioned the data from the Pain and Policy Studies Group last night. They were formed in 1996, and they published analysis of state laws and regulations. These have been critically important. He also mentioned the statements from the Federation of State Medical Boards. And the DEA and other health organizations released a statement on balance. You probably can't read this in what's in your handout, and certainly can't read this on the slide, but this was a very significant advance, that the Drug Enforcement Administration agreed to signing on to a statement about balance that said it's as important to promote pain relief as it is to prevent drug abuse. And I remember being in the office of Secretary Hutchinson. It was 2 days before 9/11. That's why I remember so well. And we were looking out on the Pentagon, and we thought, oh, is he really going to sign this statement? And he signed it with great enthusiasm, because at that point in time, the Drug Enforcement Administration said this is a critical matter, and we need to communicate to clinicians that they need not be concerned about being investigated if they use controlled substances appropriately to manage pain. Again, you heard about the Federation of State Medical Boards policy statement on the use of controlled substances for the treatment of pain. And this document creates language that can be adapted by other state medical boards. In Wisconsin, and you've got to fix Wisconsin on your slide, Bob, because our medical board has adopted a statement, but they could not adopt a guideline, because to have a guideline in Wisconsin would have required a statute. So they have adopted a position statement, but that's great, because they have said that when we have physicians to examine whose practices have been questioned, we will use this policy statement as a guide in our decision-making process. And so in the policy statement, it's clearly said physicians should not fear disciplinary action from the board. And of course, the board is all boards in the United States, we hope, for prescribing, dispensing, or administering controlled substance, including opioid analgesics, for a legitimate medical purpose and in the usual course of professional practice. So, is this the golden age of pain management? Is everything done except in the state of Montana? I mean, we have new drugs and other therapies, we have evidence-based guidelines, we have numerous professional organizations that have pain in their name. There's been this great expansion of palliative care programs. We have a multitude of educational conferences, quality improvement efforts by the Veterans Administration, by the Centers for Medicare and Medicaid Services. We have standards from the Joint Commission. We have recognition by regulatory authorities of the important role of opioids. Looks like everything's done, right? Well, I wish that were the case. This is, in a way, the golden age of pain management, because all of those advances that I listed on the previous slide have occurred. And they've occurred over the course of the last 20 years. And for me, they're nothing short of a miracle. But I am tired of hearing that half of people who are dying have inadequate control of their pain. I am sick and tired of this. This is ridiculous. And it occurs, I don't know if it occurs in the state of Montana, but it occurs in all too many places. So is this the golden age of pain management? Well, I have to say that despite all those advances, we have a lot of issues. And to start with A, abuse issues and access issues. And there are some very real questions that we have to confront about the safety and efficacy of opioid analgesics. And those questions are really creating a lot of confusion and uncertainty. So we have a lot of barriers that remain. And they don't quite fit in this standard category of barriers except for the last one, the reimbursement system, if that's what you can call what our system is. It's not quite a system. So what's the appropriate role for opioids? This is the beautiful opium poppy, the source of all joy and in many people's minds the source of all misery. If you look back at opioids, you find some wonderful statements. Sir William Osler, and those of you who are physicians would probably agree that he was probably the most influential physician in history, said morphine is God's own medicine. And then, if you read The Pharmacologic Basis of Therapeutics, the first edition published in 1941, and that's the textbook that I refer to when I teach medical students pharmacology, opium alkaloids have no rival for relief of pain. I don't think there's any question about that, is there? But then, look what Dr. L.E. Lee said in JAMA in 1941, that same year. He said, in referring to the treatment of pain in cancer, the use of narcotics in the terminal cancer patient is to be condemned. Morphine use is an unpleasant experience because of undesirable side effects. Dominant among them is addiction. Wow, this is a powerful statement. And I know that was 1941, but I find that when we look at healthcare, the professions are pretty much tend to be stuck sometimes in what kinds of attitudes existed a long time ago. So we have this challenge, and it's the dual nature of opioids. And it was expressed in those quotations. Opioids are essential for the management of moderate to severe pain. Certainly that due to surgery, procedures, or trauma, especially that due to cancer and AIDS. And certainly in selected patients with persistent pain problems that aren't related to cancer, patients who aren't going to die in the very near future. And those cancer patients, in fact, who have now morphed, if you will, into a chronic disease state, because that's what we really like to see with cancer. And on the other side of the coin, opioids have the potential to be abused. They are addicting drugs, whatever that means exactly. And so their use is subject to special laws and regulations. And you heard how the fears of those laws and regulations can affect the way people use these drugs in practice. And their abuse is increasing. You also heard about that last night. And then the other thing is that tragically opioid-related deaths are increasing in this country. So what's the risk of addiction? What do you think the risk of addiction is? Anybody? Forget my numbers.
1%.
What? 10%? 1%. Well, we really don't know, and it depends upon the patient population. Reports suggest that abuse of patients on chronic opioid therapy ranges from 3 to 19%. You guys were in the right range. But think of this, about 7 to 10% of the population in the US abuses illicit drugs. So already we've got a significant percentage who are at risk. There is no evidence that addiction is common in persons with no history of substance abuse. With no history of substance abuse, there's no evidence that addiction is common. And we don't have any data from long-term studies in diverse populations. We just don't have those data. And that makes your job hard. And addiction, as you also heard, is often confused with tolerance and physical dependence. Remember Montanans' attitudes that were told to you last night that are in the white paper? 30% said most people taking pain medicines will become addicted over time. 33% said people get addicted to pain medicine easily. Those kind of percentages go well together. 27% were really worried about tolerance. Save medicine for when the pain is really bad. And even higher percentage said take the lowest dose possible. Save the larger dose for later. Again, worries about tolerance. So folks in Montana are very worried about tolerance, and they also clearly have concerns about addiction. Now, the media reports suggest that legitimate prescribing, who are the doctors in the room? You are the problem. Doctors, raise your hand. Now all the physicians haven't raised their hand. Good, I'm glad you admit it. You're the problem. You're the folks who are contributing to this drug abuse problem and addiction and to increased mortality. There's no question about it. You're sloppy and careless. Are there data to support that? No. But you know something? Remember back in 1870, physicians were worried about what they were doing? When they gave opioids, were they likely to get people addicted? And they really didn't know what addiction was. Now, there is an increase in abuse, and here are some kind of different data. The National Survey on Drug Use and Health. 4 million young adults aged 18 to 24 used prescription pain medicines non-medically. And 17% of them met the criteria for dependence or abuse. You know something? We've worked on definitions of tolerance, physical dependence, and addiction. We don't have a definition for drug abuse. Nobody's decided exactly what those words mean. Now there's an expert panel working on defining it, but you're saying, who cares what these words mean? Well, we need to care because what those words mean can be used by the media or politicians in very negative ways. Now, when the surveyors looked at this 4 million young adults, 17% met the criteria for dependence or abuse. Where did they get their drugs? 38% said they got them free or from a relative. 20% said they bought them. I know they're available on the street in Madison. I don't know if they're available on the street in Missoula. 13% said they got them from a doctor. One young man was reported to say, there's nothing to it. I just go into the doc's office and I ask for this drug and he writes the prescription. I don't know if I can believe this. But the media loves this because it's a way of reinforcing the fact that you, physicians, are the problem. Now, there has been a huge increase in the distribution of opioids to the states. And you'll see these numbers, and fentanyl's gone up enormously. We now have the transdermal fentanyl patch. And oxycodone's numbers have gone up. Certainly, there's a lot of good reasons why people use extended release oxycodone. Morphine is not the drug for everybody. Even though it's the gold standard, folks don't necessarily do as well on that drug as they do on oxycodone. Morphine has active metabolites. They may give unfortunate side effects. The joyful news on this slide is that the distribution of meperidine is declining, and we'd love to see that. So we have a lot of commentaries and lots of literature reports. Here's one from Payne in 2004. Dramatic changes in prescribing patterns raise significant concerns. Now this study didn't look at drug abuse, didn't look at diversion. What they were doing was commenting on a report that what they called potent opioids were being used more for treatment of musculoskeletal pain, increase at 2% in 1980 to 9% in 2000. They made the assumption that it was wrong to use a drug like morphine or oxycodone to treat severe musculoskeletal pain. So just on the basis of increase in prescribing, they decided that something bad was going on. But we have other studies that are very disturbing. And there's a group of investigators from the Center for Disease Control, and I've given you a reference here to a journal you may not read very often, Pharmacoepidemiology and Drug Safety. I can hardly say it. And I reviewed this paper, but even though the reviewer said I did, or the editor said I did a great job, they let these people publish the words that they did. So they looked and found that there were increasing deaths from opioid analgesics in the United States. No question about that. Methadone deaths particularly are increasing. And they asserted without any evidence, and that was allowed to stay in this paper, that these increasing deaths were due to the medical use of these drugs and aggressive pain management. So they've made this association, and there isn't any relationship, at least in terms of data. So these are the kind of problems that we are facing. And this is the Centers for Disease Control. It's not the Center for Crazy Data. So we really have to be concerned. Now, just recently, and I actually brought the journal with me if anybody wants to look at it, a paper was published, and the data are from Denmark. The country of Denmark has the highest utilization of opioids per capita of any country in the world. Opioids are used very liberally. And also, Denmark does not have restrictions on access to data. They don't have any HIPAA, for example, or anything like that to intrude. So these investigators got data from a huge number of patients with pain. And they compared those who were treated with opioids and those who did get opioids. And here's what concerns me. They found oops, that's the wrong thing. They found, I'm sorry, I got out of place. My apologies. I should look at my slide instead of talking. Let me just back up again and not talk about that paper, but talk about another paper in pain medicine where they gave a more complex view of where the medicines came from and the causes of death. But one of the things I want to intrude now, because I'm kind of out of order here, is that when you look at opioid deaths in this country, what you've got to look at is the deaths from other drugs. And one class of drugs which accounts for a lot of deaths is nonsteroidal anti-inflammatories. Around 16,000 deaths each year from the complications of nonsteroidal anti-inflammatory drugs. This is almost the same number of deaths as from AIDS. And so the message that I wanted to give you with that unfortunate intrusion is that as we look at increasing deaths from opioids and the supposition that this is because physicians are prescribing inappropriately, we have to realize that we may be putting this not in the right context and have an unbalanced view. So what is the evidence for the safety and efficacy of the long-term use of these drugs? And again, there's real uncertainty. We cannot translate directly from the experience with cancer pain. We have few, if any, controlled studies that have examined the safety and efficacy of long-term opioid therapy. And the question is, should we be concerned about the documented effect of these drugs? They do affect hormonal systems. They do affect the immune system. And Ballantyne and Mao published a paper in 2003 that looked at these issues. There was a hope that the established success of opioid treatment for acute and cancer pain could be reproduced in chronic non-cancer pain. If only we could overcome opiophobia. That was what was standing in the way. Now I will finally get to the paper that I inadvertently talked about in this journal. And that was the data from Denmark, because the investigators looked at these large number of patients who had persistent pain not related to cancer. And they compared those who were treated with opioids and those who were not. And believe me, they did all of the necessary things to balance these two populations, looked at all the possible confounding variables. And they found that opioid treatment did not fill any of the key outcome criteria or goals. Patients on opioids didn't get better pain relief. They didn't have improved quality of life. They didn't have improved function. This is very startling stuff. And it's very concerning to me because I know personally, individually, with Ns of 5 or 6, lots of folks who are on chronic opioid therapy who are doing magnificently. But it's a challenge. Yes, ma'am.
So is that perhaps because tolerance was the issue and either patients were at a level of prescribing that practitioners were uncomfortable going higher? I mean, was that looked at?
No, it wasn't looked at, but that's always a possibility that they really didn't get adequate treatment.
Right, that's my question.
Yeah, and that didn't get addressed. There are so many questions you can ask from this, but it is disconcerting. Yes, ma'am.
June, I think the other issue is with persistent pain is that you really need to look at it not just from the opioid issue, but from what other modalities are people using, since it's not just...
Yes, and it's so important because pain management is just not all about opioids, and that's where we focused a lot of our attention. So I know, Kristen, that we're into the next hour. When we look at advances in opioid therapy, however, there are many. We do know that tolerance is not an inevitable consequence of chronic opioid therapy, that people can be on these drugs for weeks and months and not have escalation of dosage needs. And that's the point that you were raising. They can be used safely and effectively to control pain related to cancer. We know that, but we don't know if we can translate it. They do have efficacy against neuropathic pain. We know that. Although recently I've been hearing from neurologists that perhaps they work better if you combine them with another drug, such as pregabalin or Neurontin. And then we also know, finally, why there are such wide variations in response to opioids, why one size does not fit all. And that is because there clearly is genetic polymorphism in receptors. Kristen's opioid receptors are not the same as mine, are not the same as yours. So why should we need the same dose of drug? Why should we assume that one size fits all, and that when somebody doesn't respond as we predict they should, that obviously they are a drug seeker? So we have to put that in mind. Abuse and addiction, there's a question of access, and I think you're going to be talking about this because this is addressed in some of your recommendations. We have a lot of people who are uninsured. I don't know what the numbers are in Montana. Nationwide, it's something like 47 million. Dr. Twillman talked about the restrictions of drug formularies. There's a tremendous lack of reimbursement for interdisciplinary care. Who pays for time? Time is not very sexy, is it? But an intervention is. So what are today's objectives? I left this blank because this is up to you. What do you want to get out of this day? What do you want to go home with? What are your dreams and hopes for the citizens of Montana? You need to fill out this blank. And I'd like to see it by the end of the day. What do you plan to do on Monday to make a difference? Forget about what you decide in your breakout groups, but think about what you personally are going to do, because you can make a lot of change. You need to network and you need to get energized when you develop these policies and you work to implement them. You need to identify the way you can get involved. And I leave with a quote from Margaret Mead that you're all very familiar with. Never doubt that a group of thoughtful, committed, a little bit crazy people can change the world. Because that's the only way it's ever been done. So that's your mandate for today. And of course for the months that follow, because this is not an easy event. I started working with the Wisconsin Pain Initiative in 1986. In December, we developed a strategic plan. We're still working on that strategic plan. And then more things have gotten in the way and have intruded that have prevented us from accomplishing some of those goals. So good luck to you, and thank you very, very much for allowing me to talk with you. I wish you well, and I thank you for all that you've done. Wonderful job, great beginning. And we're going to clone you, at least.
Thanks, June. Our next speaker is Ann Corley. She joins us from the Missouri Pain Initiative. Ann Corley holds an undergraduate degree in business administration and a master's degree in counseling psychology. And she is going to talk to us about the Missouri Pain Initiative. And when our conference planning team was looking at trying to move our launch our pain initiative, we really wanted to look at an existing initiative that had taken a strategic approach and it was doing some good work, but also was facing some challenges. And so we talked with the Alliance for State Pain Initiatives and others, and they recommended that we invite Ann, and we welcome her. Look forward to learning from you. Thanks.
Thank you. Thank you. Can you all hear me okay? Well, it's great to be in Big Sky country. It's a beautiful, beautiful state. I think the last time I was here in 1977, and I was on a summer vacation from college and was considering law school. And is there a law school here on the campus, right? Yeah. So that was the last time I was here in Missoula. I had a change of heart in the middle of one night thinking I'd have to sell my soul to become an attorney. Please don't take it offense if I have attorneys in this room, but I decided that was not the path for me. but it's been a fairly circuitous path to be here in front of you today. I do not have a healthcare background. As Kristen mentioned, I have a bachelor's degree in business administration and a master's degree in counseling psychology. So my journey into the Missouri Pain Initiative is a little bit probably unorthodox. I also don't live with chronic pain, and no one in my family does. So I'm sort of an anomaly to come into this. It's usually the folks that I meet that are very, very involved in this issue, either are pain professionals and some of them being chronic pain sufferers themselves, or they're people living with chronic pain. So I'm here to tell you, you can convince those of us who stand outside that circle to come into your circle, because I have, and I'm happy to be here today. I've added a few extra slides based on some conversations that happened last night, so they're not going to be in your handouts, but I thought they might be worthwhile to talk about. The state of Missouri does have a Missouri Advisory Council on Pain and Symptom Management. Bob Twillman mentioned that last night. It is a separate entity, and it is separate from the Missouri Pain Initiative. It was established within the Department of Health and Senior Services in 2003. There are 19 members that serve on that council. There is a chronic pain designee, health professionals. I should remember what PRMA, it's the pharmaceutical representative, I can't remember what it stands for. Legislators, a state senator from both parties, a state representative from both parties, an advocate from voluntary health organization, and a designee of the state's attorney general's office. That person being on because the attorney general's office in Missouri has statutory authority for consumer protection, and we consider pain management to fall under that umbrella. And so that group has been together since 2003. Their duties were, so you're going to see some similarities between this and your task force. They were to review the state statutes and guidelines, make recommendations on the acute and chronic pain management treatment practices and how to integrate them into customary practices, and to examine the needs of targeted populations. They held 4 town meetings in 2004, and as was mentioned last night, their meetings were not well attended either. Mostly it was pain professionals. There were a few folks that live with chronic pain or suffer from acute pain that showed up, but mostly it was practitioners and policymakers. But nonetheless, these were sort of the topics that shook out: provider and consumer education, mostly the lack thereof, vulnerable populations being the elderly, the young, the poor, the minority, no surprise there. Funding issues, we're talking about reimbursement. Access to specialty, alternative, and multidisciplinary care, we've talked about that because it's not reimbursable. And transportation resources, I don't know landmass-wise how Missouri compares to Montana. We probably are half your size. But just transportation issues for the rural population is a huge, huge issue. And then the legal issues, policies that aren't serving what we need to get done. Some of the activities that were started out of that, some of these are finished and some are ongoing. They have developed a joint policy statement. I think that statement's been ready for about a year. I think I mentioned who serves on that advisory council. There is a member from each of the boards: the Board of Healing Arts, the Board of Pharmacy, the Board of Nursing, Board of Dentistry. And in spite of the fact that that representation is on the advisory council, that joint policy statement's gotten nowhere in terms of being adopted. It's just taking a long, long time. I'm not going to say it's not going to happen, but the wheels are grinding quite slowly on that. They are currently working on eliminating the ambiguous language. Like Montana, we have a C+ also on our policy and regulation report card. And so we are working on, the advisory council is working on that ambiguous language in the state statutes and regulations. Again, I don't think they'll make the progress they need to this year. That's probably looking into 2008 on that. What is a really neat thing that they've gotten done, though, is they do have a web page on their site. I think I had that on the previous slide. I think I've got it again. I'll make sure I'll get it to anybody that wants it. But it's on their site specific to pain and symptom management, and there are a lot of great links from that site, and so I would encourage you to go out and look at that as you all are forging ahead. They support continuing medical education efforts. They did and continue to have a long discussion, ongoing discussion about mandatory CME, and there is so much resistance from the members that come from the various boards to that. Their logic being, if we pick out pain as a mandatory topic, what's going to stop us from picking out something else and something else and something else? And we actually surveyed, we being the Missouri Pain Initiative, I'm going to call it MOPI, okay? I'm going to start shortening it. MOPI is Missouri Pain Initiative. MOPI actually surveyed some our pain professionals in the state, and they overwhelmingly said, no, we're not interested in mandatory CME. So lack of interest from the population and lack of interest from the boards on both sites. Partnership with MOPI on statewide strategic planning process and our public education piece, and I hope to get to that in just a little bit. If you want more information, that's the website you need to write down, okay? I'll leave it up there for just a second. And again, I apologize for adding these at the late date, but thought that might be helpful to you. And again, we work very closely in tandem with the Advisory Council. Up until January, 2 of their council members were 2 of our board members. One of our board members retired, but he's still an active member of MOPI, but we still do have 1 board member that serves on the Advisory Council. And they do get some funding from the state, a modest amount, but they've been very, very generous with that with us. It's helped to pay for some things that we've wanted to do. So they have helped us and we have helped them. It's been a very, very positive relationship for both of us. Okay. These are not, the next few slides are actually, I thank the Alliance for State Pain Initiatives for giving me the permission to use these. They used that for a presentation that they made to us at a function that we had, and I thought they might be helpful to you all since you're not necessarily so familiar with the Pain Initiative. What the heck are they and what do they do? They're often a partner that are affiliated with other organizations, as yours is starting out to be with the American Cancer Society. Some are independent nonprofits. They rely mostly on volunteers. Very few are in our situation. I am a part-time paid professional staff. That is rare. Usually it's done through volunteers. They do develop priorities and projects around needs that are specific to the state. It's interesting to see that the commonality of issues being discussed today, but there are some unique needs being discussed here. They also look at available resources and the skills and interests of those involved. The experience, there is an ebb and flow. Some are active for a while and they go inactive, and actually that was the case with the Missouri Pain Initiative. We actually started out, I believe, in the early 90s associated, it was the Missouri Cancer Pain Initiative associated with the Heartland chapter of the American Cancer Society, I believe it was. I'm not from that history. I really don't know anything about it. I just know for whatever reason it wasn't successful, and I think they had some record-keeping issues. But so we are actually, this is sort of the second gyration of the Missouri Pain Initiative, but hopefully it will be the one that continues on. That gives you a map, and maybe the colors are hard to see here. No, I think they're pretty good. Established, there are 32 state pain initiatives right now across the nation. You are considered an established pain initiative. I don't know if that's shocking to you, but there are 5 right now forming and revitalizing, and 15 are presently inactive, which maybe they never existed, or they've had to downsize or chosen, or their mission has been completed. These are the different kinds of partnerships. The color of your state signifies that you're associated at this point with the American Cancer Society. That's looks like 10 of those. 7 are independent. That's us. We're an independent 501c3. There are quite a few that are associated with the end-of-life organization in their state, and a number are affiliated with an academic institution or a cancer center. So again, I think that's a little bit helpful information to see that there are some differences among the pain initiatives as to how they home base themselves. Current programs that you'll find state pain initiatives involved in are capacity building, building the mission and the projects of the pain initiative. Institutional change, trying to change systems and how pain care is delivered. Policy and advocacy, professional education and public awareness. So a lot of the same similarities. 3 or 4 of these are the breakout groups for you all this afternoon. So very similar overlap. I wanted to talk for a little bit about the stages of nonprofit life cycle, because I think at some point you're going to be addressing this. It's an issue that we're addressing. We're in perhaps a different stage than you are, but there are challenges that come towards you as an organization, as a nonprofit organization, that you've got to navigate through to get to the next level. So that's what I'm hoping to do, is to tell you a little bit about our journey from one stage to the next, and talk about where we're at now and the challenges that we face. In doing that, I also hope to tell you a little bit about some of our projects and activities, so perhaps as a way to spur discussion this afternoon about some ideas that you can all consider to make your own. So those are the stages: the idea stage, startup, growth, maturity, decline, turnaround, and terminal. I'm putting you all sort of in that first idea, transitioning into the startup stage, and I would put us right now in the growth stages where we are. So the nonprofit idea stage asks the question, can this dream be realized? And I think this afternoon is when you want to answer, yes it can, and how are we going to do that? So startup says, how do you pull it off? Once you start to make some plans, how do you put those plans into place and make it happen? Growth, that's where we're at. How can we build this to be viable? Are we a busy pain initiative? You bet. Do we have a lot going on? You bet. Are we viable? I'd like to think we are, but it's a perilous journey. You know, you're only as good as how much money you have in the bank and how much you can keep things going. So it's a constant challenge, but I'm also here to give you a message of hope. You can make it happen. Things tend to align themselves and show up, resources show up when you need them. I think at some point, hopefully in the fairly near future, we'll reach the maturity stage where we can ask the question, how can the momentum be sustained? MOPI in 2003. These are the different elements that you have to address in order to move your nonprofit on. So one is the governance. You've got to start a board, find people willing to serve, draft some articles of incorporation. And again, the decision was made right away for the group that formed MOPI at that time to make it a 501c3. They did create a board, and this again is before I'm on the picture. I don't show up for a few years here, folks, so this is before me. But they did have an 11-member board, very heavily focused out of the St. Louis area, which is one of our urban areas. I think 9 of those 11 members were just from St. Louis, so it was almost more a regional pain initiative than it was a state pain initiative. The leadership that they drew to MOPI came from the steering committee, much like you've got a steering committee for this pain initiative. So that was the staff leadership. The financing, you've got to scout out your funding resources. They weren't savvy enough, nor knew enough, nor had the kind of financial people on board to do a business plan. They just sat and thought, how the heck are we going to get some money so we don't all have to volunteer all the time and we can eventually get some staff? That was their question. And they answered it by saying, we're going to have a pain conference. The state of Missouri didn't have a professional pain conference prior to that. I stand corrected. There was a pain conference, I think, that had been offered once or twice by the American Society for Pain Management Nursing. But we felt, I guess the organization felt that there was opportunity to draw perhaps a different audience or offer it at a different time of year and attract a new audience. So that's immediately what they decided to do, because the thinking being, if we can approach the pharmaceutical industry and get underwriting support and unrestricted grant money, hopefully what we pull in is going to be less than what goes out to pay for meeting room costs and that sort of thing. And so they were hoping there would be some money left over to hire some staff. So I'm pretty sure that was the logic along the way for that. The administrative issue that you have to figure out is decide where you're going to be housed and your compliance requirements. MOPI decided to house themselves in the WashU, or Washington University Pain Center in St. Louis. They really felt an academic affiliation was important for them. It would help with the CME provisions and that sort of thing, but also just lend some credibility. So that was the affiliation. It was really very loose, I must say, though. There was a P.O. box there, and I think that was about it. But a lot of the WashU Pain Center did go on a lot of the literature. Staffing, what were the staffing needs? That was all filled in again, still with volunteers. The incoming president, who is a PharmD, his name is Chris Herndon, perhaps some of you know Christopher, just gave the time that was needed, gave of himself to do it. I think kept the MOPI financially afloat himself personally in the beginning as well, just made that kind of time commitment So I think was just willing to hang in there long enough to get the dollars to help get some staff to help with that. The products and services, again, was the professional educational conference. The other thing that Chris did, though, too, is I think was a great product and service, but proved very, very difficult, too time-consuming, and not something that he could keep up, was to have a quarterly newsletter online. We did have a website. He started that. But he also did literature reviews, which was very nice, but very tedious and time-consuming. And so I think after about 3 or 4 issues, that got dropped. As far as marketing, you've got to try to generate some enthusiasm for your concept. You've got to figure out what the demands and the needs are and figure out how you might start to create a message and a brand. Again, I think they turned a little bit to WashU for help. Really, the only marketing that I'm aware of that they did at the time was to advertise their pain conference. So that was MOPI in 2003, sort of moving through that idea stage and into that startup stage. So here we are in 2004. Governance, what has to happen then is you've got to try to create a more formal governance structure, expand your board, and provide board training. It was at this point that bylaws got developed, set a due structure. You could join MOPI at that time for $20, whether you were a professional, an individual living with chronic pain, someone interested in it, you were a corporation or an organization. It did not matter. That was the dues rate. They did have some meeting requirements. I believe they agreed to meet 3 times a year. That proved probably fairly easy because, again, most of them were living in the same geographic area. And they did have elections. They did set themselves up as a member organization, and because of that, we agree that we will have a general member meeting once a year. So that has some requirements that go with it, that too. As far as staff leadership, they did have the intention that they did want to hire someone as an executive director. They had to wait till after that first conference was completed in November 2004. How I got into this was I was actually hired by an organization called the Missouri End of Life Coalition. I had worked in hospice for a few years and I enjoyed it, but I decided I really wanted to work for myself, so I left healthcare and was sort of looking around for what to do when it was actually approached by the coalition to see if I would consider being their executive director for about 20 hours a week. And there was an overlap of one board member to the other. And she approached me and said, well, we'd like to hire you for 5 hours a week. Would you be willing to do that? And I'm thinking, gosh, what can I do for 5 hours a week? But hey, it sounds interesting. And pain initiative, huh? What could that be about? So my curiosity got the better of me. And that's actually how I got hired. It wasn't anything really fancy, but I was hired again for 5 hours a week. And let me tell you, it's difficult to run an organization on 5 hours a week, no matter how small it was. But we tried it, and I think anyone who takes on this kind of position, you just expect you're going to be giving away some of your time. There's just no other way that it's going to happen. So, such as it is. The financing part, again, they got money in for their professional education conference, and also got a first grant. That actually happened in 2005, shortly after I started on. Our very first grant, it happened to come from the Alliance of State Pain Initiatives, and it was to fund something called the Show Me Urban and Rural Education Project, and I hope to have maybe time to talk about that in a few minutes. There was no budget. Again, not sophisticated enough to do budgeting and financial reporting. I remember looking at their very first treasurer's report going, oh, we call this a treasurer's report. Okay. Because coming from a business background, I was like, we call the bank balance a treasurer's report. All right, that works for you. So that was a little bit of a challenge, helping to get people more acclimated to the business thinking. And that reminds me too, I can remember when they were talking about the next conference, because as soon as I joined, they were already making plans for the 05 conference, and I can remember hearing one of the board members say to the other, well, we're just going to be happy if we break even. And I'm like, oh no, breaking even is not acceptable. This is, I'm already starting to talk the language of sustainability with them. You've got to be able to, this has to produce revenue for you. If it's not going to produce revenue for you, you've got to ask yourself why you're doing it. Because again, You have to complete your mission as an organization, but you have to be able to sustain your organization. And so you have to be able to look at things that are prudential revenue producers like a conference and say, breaking even is not an acceptable thing. We've got to come out ahead on that. So anyway, I think that was, a change of thinking that the board had to go through, and they were willing to do it. My hat's off to them about that. Administrative establishing an office. We kept the P.O. box at WashU and kept that affiliation, but obviously I worked out of my home-based office. That's where that happened. Again, I'm the staff, 5 hours a week, and what helped me keep it fairly close to that 5 hours a week is that we had a very, very, very active professional education committee, and they pretty much handled the professional education conference. There was very little that I had to do with that, at least that year. Products and services, again, it was about repeating the conference and then our SURE initiative. And maybe let me just talk about that for a minute. The Show Me Urban and Rural Education Initiative was our attempt to try to address what we felt was a need for professional education opportunities that came to the provider instead of forcing the provider to come to a conference. We'll come to you. So the Alliance of State Pain Initiatives was generous enough to fund our request, and it enabled us to pay some of the volunteers in our organization to go out to various hospitals or mini conferences or for grand rounds and present on pain topics. We put together a list of 20 topics, and we had probably that many volunteers willing to do those talks as well. And we tried to market and advertise to all the various organizations across the state to let them know that we had this service available. And I'm pleased to say that I think that year we presented something like 13 or 14 talks. So what was interesting was once we got through the effort of putting it all together, how much work it took to get those talks used up. It was, you can put the opportunity out there, but it doesn't guarantee that people will take advantage of it. But for the talks that we did have, I think 11 of those, the presenters will tell you were incredibly successful. On only one of those was it a mandatory CME, maybe this is telling, a mandatory CME, and the attendees acted like hostages, and it was not a pleasant experience for the provider. So anyway, our learning experience nonetheless, and we have kept on with the SURE program. When the grant funding ran out, we decided we'll continue it, but we do charge for it now, and I think we've only had 1 or 2 requests since then, but we still think it's a valuable service for us to be able to offer. Marketing, developing a fact sheet and developing your brand. Still didn't have our fact sheet developed, but we came up with some cool buttons. I should have been wearing one today, darn it. And it said, Missouri Pain Initiative, helping those who help those in pain. Because what you have to understand is where MOPI was at that point is we were very, very focused on professional education. We hadn't really thought beyond helping professionals do what they do better. So helping those who help those in pain was our motto that we developed at that time. Moving through the growth stage, because I'd say quickly, towards the end of 2005, we hit what I would call the growth stage, and we're still in that now. So what did we have to do now, and what are we doing now? It's the governance piece, is to systemize the board recruitment process. The kind of board members you need at the beginning in an idea phase are not the kind of board members you necessarily need further on. I see heads nodding, you get this. Your board members oftentimes early on are the people that do the work, they make the projects happen. They're the ones that are the presenters at the conference, they're the ones going out to the pharma companies asking for the money. They're filling a lot of different roles and a lot of different hats. As you evolve and mature as an organization, what I think you will find is that those needs change. When you get to the stage we're at, you know what you need a board member for? You need them to bring money, their own, and they need to go after people with money. So you're looking for a different type of board member. Their role, their responsibility changes. I think we're at the stage where you have the board member philosophy of give, get it, or get off, is what I've heard. That sounds rather cold and cruel, and I don't mean it to be, but again, when you're in the stage that we're at, your financial stability becomes incredibly, incredibly important. And one of the conditions of the early board, it was never mentioned that you would have to donate. You joined for $20, but there was no expectation that as a board member that you would give money to the Missouri Pain Initiative. We have changed that expectation. It's now written into the roles and responsibilities of our new board that as a board member, you will donate to the board. We don't set that amount, but we're trying to create the expectation so that when I go out and I'm trying to ask for money, I can say 100% of our board donates to the Missouri Pain Initiative, because I think there's some power in being able to say that. So we had to refine roles and needs. We had committees and we had no committee roles. I mean, when I came on, there were these loose committees, and I said, okay, can I read the roles and responsibilities? Oh, well, we don't have them. So that's another thing. Just because I come from a business background, I said, we've got to sit down and do this. And so we did, and have been doing that. Staff leadership, I started out with a very, very loose contract. They contract with me. I'm considered a contract employee. I don't get benefits and that sort of thing. And that was fine in the beginning, but later on, I think we both, the organization and I, realized we really have to get more down on paper. So, of course, I write my own job description. I love that, but wrote it. But I think it's a much better place to be in with a more formalized structure that way. And we've looked at obviously I'm not working 5 hours a week for this organization anymore. I try to keep it to 20, and even at that, it's a real challenge at this point. Create a fundraising plan and develop a multi-year budget. Again, these were new concepts, and we've been able to do this, so it's all in a matter of being able to tackle these things as they come along. I think we started out with, I think, a budget. I don't know what their budget was in 2004, but in 2005 it was about $15,000. The budget in 2006 was $70,000. That's how much it grew. And I have our budget we approved that I put together is $125,000 for 2007. So that's how fast you can grow as an organization, depending on what it is you're doing and the activities that are involved with that. In 2004, our membership, I think we started out with about 30, by the end of 2003, I think they had about 35 members. In 2004, it grew by 38. In 2005, it grew by 39. And in 2006, it grew by 46. Are they all active? No. Are the majority of them active? No. Do I keep them well informed? Yes. And are they always invited to the table? But that's, again, I think one of the challenges of a large statewide volunteer organization. You can have things that you're doing in activities, but when people are spread out geographically, or perhaps they just don't necessarily feel that particularly invested. So that's one of the challenges that we have and we are trying to face right now, is how to get more of our member volunteers involved with the organization itself. How much time do I have again? Oh, yikes. Okay, we're going to be flying through this stuff. We looked at trying to hire more staff. Actually, for a while, I stepped out because actually I'm an idea person. I'm a catalyst. I'm what people describe as a visionary. I'm great at starting stuff. Sticking around and following through is sometimes not my bag. But but I decided to be a grants coordinator because I wrote all these grants, and lo and behold, they all got funded. It was a beautiful thing, and so I really wanted to make sure that they got through okay. And so I decided to be grants coordinator, and we tried to hire an executive administrator. That did not work out. I was, at this point, invested enough in this organization that I stepped back in as executive director and plan to stay on for a good while yet. But I think at some point we have to look at having some staff to help me because I'm getting more expensive, and I think sometimes it pays to just have some of the more easier tasks and tasks that perhaps sometimes I'm a little overqualified for. Some of the purely administrative stuff to do, could use some help with that. What other things that we've done is we have updated our website, and I invite you all to go out and look at that. I hope you will. I think it's on my paperwork, but it's www.missouripain.org. Really proud of the website and try to keep it relevant and current. We just got new member and donor software, and I want to give you guys a heads up about this as you build your member base. There's a wonderful company out there called eTapestry. And if you have a membership base of 500 or fewer members, you can get the software free. And it's incredible the profiles you can create on your members, and you can hook members together with different personas. So that if I join and my husband joins, you can look me up and hook over and realize, oh, that her husband, Don, is also a member of the Montana Pain Initiative. So somebody make a note about that and look into that as you get onto your membership roles. This is our governance structure. It's probably hard for you to see, but we have a board of directors, and we also have an executive committee. That was added. Our bylaws were amended in 2006. Again, this is because I came on board and said, there's too many of you. We need to streamline this. I need to be able to go to a smaller group of people and make things happen in between these 3 meetings a year. So we created the executive committee. They do report to, they don't replace, they report to the board of directors, but they're to take care of the in-between things, the pressing, more urgent and important things that happen in between meetings. And so my executive committee and I meet once a month via phone call. The board of directors, we have 4 face-to-face meetings a year and 2 phone calls a year. We've upped all those meetings, but we just need that kind of time together. You can see on the membership structure, we did some changes. We don't charge $20 anymore. We would like you to join, and if you join, it's $30 if you're a member of the general public, $50 if you're an individual professional, $100 if you're a professional organization, and $250 if you're a corporation. And I've just now finally instituted a membership drive. All of our board members, that was the expectation this year too, that they would help with membership. So they've all been supplied with letters and letterhead and envelopes, and they also are trying to solicit members. Again, we're trying to diversify our funding base, because I'll tell you right now, you saw those budgets, you heard my budget. My 2006 budget of $60 whatever thousand, 90% of that was grant funds. You cannot, as a nonprofit, I know this, the business person in me knows this, you cannot sustain yourself if you've got that high of a mix of grant funds. You have got to diversify your funding base. So we're trying to build the membership roles, and we're trying to do donor development, including individual donors and corporate donors. So, and then we have the 4 committees under the board. Sustainability. If you are the chair-elect or the president-elect, you are automatically the chair of the Sustainability Committee. Why? Because you're going to invest time in sustainability so that when you get to be president, you've got an organization you can run. So that's the tie-in. We also have a policy committee, a professional education committee, and a public education committee. What's our mission? There it is. I like to simplify it because I'm not a healthcare professional. I simply say we're trying to improve pain care in the state of Missouri through education and advocacy and changing the healthcare system. Kristen did mention our strategic planning. I took that group through strategic planning in May of 2006. I'd been there already a year. But in that time, I again am one of these people, I need a roadmap. I don't know where I'm going if I don't have a roadmap. I just sort of operate that way. So I helped start to put the pieces of that together. And we organized that strategic plan by 6 focus areas. I think you're going to see a lot of similarity to what's going to be suggested to you all later today. These were the areas: provider practice improvement. Notice it's not professional education, again, because education doesn't necessarily change behavior. So this is a much more proactive term. Public engagement and self-advocacy. It's not public education. Education doesn't necessarily change behavior. Public policy and system change, sustainability, governance, and collaboration. So to start out with strategic planning, it helps to start out with a big question. And this is the big question I asked the group. I want to know what the most important things are you're trying to achieve in terms of completing your mission. And what's our mission? We want to improve pain care in the state of Missouri through education, advocacy, and system change. So what are the most important things we can do to achieve that? And for each focus area, we came up with a strategic priority. So for the provider practice improvement, it was to bridge the gap between the existing knowledge base regarding effective pain assessment and treatment and current practice in Missouri. And again, because through the town hall meetings that the advisory council held, and just through our knowledge base as an organization and who's in the organization, we realize, as you have talked about, we know how to treat pain. We know how to relieve a good deal amount of the pain that's out there. But are we putting it into practice? No, not nearly enough. Not nearly enough in the state of Missouri. I can tell you this, we did get some grant dollars to help pay for a survey to go out with the SURE initiative, and we were able to survey almost 400 pain providers, and the majority of them were physicians, because you're probably not aware of this, but Missouri is only one of 3 states that do not allow advanced practice nurses to prescribe. So that burden or privilege, or however you want to look at it, falls mostly on physicians. 57% of those we surveyed had not attended a pain CME in 2006. 49% said they had no intention of attending one in 2007. 81.4% felt able to manage pain adequately to extremely well in their patients. 81.4. But 58% recognized their patient satisfaction with care was adequate to poor. A little bit, maybe? Yeah. So, hence the strategic priority there. Moving on, public engagement and self-advocacy. We were fortunate in January of 2005 because the American Pain Foundation saw fit again to approve a grant application I submitted for us to be declared an American Pain Foundation and Alliance of State Pain Initiatives Power Over Pain State Partner. They've since sort of replaced that with another more broad program that they're trying to incorporate in all 50 states. But we became a Power Over Pain state. And what came with that were some wonderful PowerPoint slides to do a community presentation. We've got all kinds of great literature from the American Pain Foundation. And if you haven't looked at that literature, I'd invite you to go out to www.painfoundation.org. They have a wonderful, they put all their pain community newsletters online. You can go back into their archives. I just sat on the plane with a lovely woman named Joan who lives 35 miles from here. Yesterday when I was on the plane, and she's suffering from shingles, so I need to follow up with her when I get back and send her the link to that issue or send her a copy of that issue. And had I had more room, I would have brought a few of those with me. But lots of great information, and they had pain pamphlets that we were given, and so we just ran with that. I mean, that was a gift. There was also money to just pay me to coordinate the program. It was a real godsend. So empowering consumers to demand more effective pain assessment and treatment was one of our priorities, because again, out of the town hall meetings, it was very clear that the general public has a difficulty knowing how to talk to their provider about pain and don't even understand their rights to have their pain legitimized and treated. So again, it's very proactively focused. It's not education focused, it's empowerment focused. Because again, here's a conclusion we're coming to, and this is why we're moving into the arena of reaching out to those, and those of you in the audience here that are here today that live and suffer with chronic pain, you are going to be the true change agents. We've been working on the professional community, and we make strides, and we've made some strides, and we'll make some more strides. But you will be the tipping point. When you and your collective voices come enough together to demand better care from the health community. I think we believe that's when it's going to happen. So that was a new piece for us, and that was a real shift, because we had a lot of board members really comfortable with planning pain conferences and giving talks, but the whole idea is, we're going to do public education, but it's made a great transition to it. Public policy and systems change, supporting efforts to improve pain policy within the state of Missouri. Again, that really has been looked at more as the role of the advisory council, because they're the ones looking at the ambiguous language and those kinds of things. But we as an organization had never really put ourselves on the line for any sort of advocacy thing. And as I said before, advanced practice nurses and nurse practitioners cannot prescribe controlled substances in the state of Missouri. Okay? They can't prescribe anything. And there have been bills introduced in the last few years of the House or the Senate or both. And last year was the very first time that we as an organization went on record saying, yes, we support that. And it was difficult to get the board convinced to do it. just because there was a fear of ticking off certain segments of the professional community. So it took me as an outsider, and I think this is when it's helpful, when I feel sometimes I have a helpful role because I don't have any baggage, I don't work in healthcare, I don't live with chronic pain, to say, will you please look at your mission and tell me how you can live your mission and not support this bill? You'll have to convince me, and if you can convince me, then I'll be quiet. But I think it's my job as your executive director to point out, you know, your opportunities and your responsibility to live up to your mission. So they did go on record as supporting it, and we went even a little further this year. But unfortunately, I think we're going to end the session again with a totally gutted bill. There was so much opposition. I think the last thing they're down to is they'll let them prescribe Schedule 5 medications, which, yeah, do a lot. So anyway, governance. Create an organizational structure and operating policies that are responsive to our developing needs. And again, that's part of that revising that I talked about a little bit. And then collaboration, huge, huge deal for a few members of our board, and I believe in it totally. That whole sense of looking for opportunities to partner, because there is so much opportunity out there. And I will tell you though, all those members I mentioned, those 140 some, they're mostly individuals. They're not organizations. We're not an organization with heavy membership of other organizations. We're an organization with membership of a bunch of individuals. So we really wanted to do our work to try to reach out to these other organizations and agencies across the state who are interested or might have an interest in pain as perhaps something secondary to their mission. Now, action plans, you have this strategic thing. You're asking what are the big things we need to accomplish. And then your action plans say, okay, how do I do it? You have to break it down into smaller steps. So we put together this whole thing. What are the steps? What are the timeline? What are the resources we needed? Who's responsible for getting it done? Provider practice improvement. We wanted to develop a collaborative plan for increasing provider knowledge. We had that SURE initiative, we had our annual conference, but we decided that that wasn't enough. And I'm excited to say that, I'm going to make sure I'm getting on the right page with my notes, that we are going to try something. Do you see underway with the Prescriber School project? You're curious about what that might be? Again, knowledge doesn't change practice, but what is it that's keeping those family practice docs in rural Missouri from being willing to prescribe controlled substances? They fear regulatory scrutiny and they don't know what to prescribe. So we feel, you know, we've gone the professional education route. They're coming sporadically to this stuff. We'll come to you. We're not asking for it, so we just took it another step. What is it we need to do? What's the next thing we need to do to try to change behavior in the medical community? And we had just had the fortunate addition of an attorney on our board who lives with chronic pain, and many, many of her clients are physicians who have gotten their hands slapped by the medical board or by other institutions, whatever. Anyway, she, at our retreat, said, why don't we put together something that helps them learn how to stay out of trouble? And the idea was born. We could probably call this the appropriate prescribing workshop, and I have a feeling we'll change it to something like that. But we have plans underway to put together a one-day workshop to reach out to these, because it's the people on the front line of medicine, as I can't remember who this physician was sitting up front here said. They're the ones, you know, they're the line of first defense. And if you don't have that much training, and you don't, as Catherine said, and you don't have that much knowledge, it can be a pretty scary thing. And although less than 1% of the physicians get in trouble with any licensing board, the fear of getting in trouble is huge, and it creates a huge, huge barrier, especially in the state of Missouri. So we have put together this one-day prescribing school. We do have our State Board of Healing Arts on board. They're going to participate. The Regional Drug Enforcement Agency is going to participate. Our State Bureau of Narcotics and Dangerous Drugs is going to participate. And they're going to learn risk management. They're going to learn how to do the record keeping. They're going to learn what it is they need to do to be from an administration and from a record-keeping point, how to do what they need to do to stay out of trouble. And we're going to sneak in 2 or 3 little units of pain assessment and management. Because my truth is, I don't think they're going to come for that. They're going to come to learn to stay out of trouble. But we're going to sneak in some pain assessment education for them too. And so stay tuned. And I'll talk to you another year or so, and we'll see how we came out with that. Continuing that Show Me Urban and Rural Education Initiative, again, that's still ongoing. I'm really excited about number 3, and I do want to tell you about the dates of this in case you're interested. We are working with the Missouri Hospice and Palliative Care Association. That is a great organization, and they have had a conference, I think, for about 18 years. And we've approached them, and they've agreed to add a pain management track to that conference. Putting on our own conferences proved problematic. Again, we're not getting the kind of turnout we want for it. They draw 500 and some people to that conference. I know because I volunteer at it every year. So I approached them about the possibility of doing it. They wanted to work with us, and we wanted to work with them, and I think it'll turn out to be a good thing. But I'm happy to say Dr. Richard Payne of Duke University is going to be one of the keynote speakers, and he's also going to do a pre-conference workshop on pain management. So write this down. It's October 28th and 9th in Kansas City at the Hyatt Regency, and I'll promise to even be a chauffeur for you if you come into town. And then to partner with the Alliance of State Pain Initiatives on the Pain Improvement Partnership Project. Again, we were one of 2 states chosen in 2006 to pilot this project, but it's aimed at better pain assessment and treatment in long-term care facilities. And we are getting to the end of that project, and I actually am going to be attending a meeting in 2 weeks with June and some other people from our board to sit down and ask, can we replicate this across the state? What would it take? And again, I am going to be looking at it from the filter of sustainability. Can we do something that's going to help us financially as an organization to move ahead? So what is it we'd need to charge a facility to be able to have us take this information to them and educate them about it? So if it can't be sustainable, it's got to go off our plate right now, because we cannot take on any more projects that don't bring in money for us as an organization. And that's just part of the tough job of having to work smarter as an organization. You just have to pick and choose those kinds of things. Public education and self-advocacy. Somewhere I lost a slide in here. There's more than one thing, but I only have one slide in here. MOPE had a strategic plan. We put it together. And again, I told you our organizational members are just mostly individual members. We wanted to reach out to a lot of larger organizations, so we put together a statewide strategic planning process, and we had about 40 different organizations come and do that with us. We have a fabulous Pain Awareness Month, and again, I'd encourage you to go out to the website for MOPE to look at that to see what all we were able to accomplish. I need to back up there, because this is the stuff I don't have in this, and I really don't know why. But we have put together a booklet called Managing Pain Begins With You. This is where the advisory council comes in. They used their money to print these for us. We worked on the language together. They went through, I think, 19,000 of these. It's on its second printing. They've been able to print 4,000. And I'm just going to put these on the end of each table and encourage you to look at those. You can download a copy of that free off of our website. You can order those. They are not state specific, so and very, very helpful. They, I think, give a really great overview for someone in pain on how to ask the right questions, communicate with their physician, and take a more team approach with their physician on how to address their pain issues. Another thing that we're doing in terms of public education engagement is the president of our current pain initiative is a chronic pain sufferer herself. She's also someone who's done geriatric case management for 30 years. She wrote a wonderful guidebook. It's called Beyond Chronic Pain. This is a pre-publication copy I'll hand around for people to look at. But it's a 95-page workbook that addresses the emotional, social, spiritual, as well as physical aspects of pain. So as I'm thinking today about what you all are saying about we don't do a very good job with the behavioral stuff, that guidebook I think is a wonderful tool that we have. We sell it. So I'll do my little sales pitch here, and I don't mean it that way. But it's a great resource, I think, if you have a pain management clinic and you don't, it's a resource that you can use when the pain patient, that lifelong relationship you have to have with these folks when they're coming to you and you're realizing that they're still going to go home with some of the emotional and psychological or spiritual issues associated with pain can be very, very helpful. One of the cool things we're looking at doing right now with that is putting together a facilitator guide and model for starting pain support groups. And that might be another opportunity for you all to consider in terms of how do you address that gap in the behavioral part of the whole pain issue. So we're looking at putting together a facilitator guide and a model that would be a companion to that book. So some possibilities there. We have had a pain advocacy day. That was our very first one. Somewhat successful. I think something we'll try again. Sustainability. I'm going to be talking about that this afternoon. That's my breakout group, so I don't think I'll spend much time on it now. I need to wrap up anyway. But there are a lot of, again, you've got to be able to sustain your organization and sustain your activities. It's really great to dream about the things that you want to do, but you've got to build that foundation. And so this is really not a sexy part of the topic, let me tell you, because it's all process. So, but if anybody's brave enough to be in my group this afternoon, we're going to talk about the process of how do you build the infrastructure to keep your Montana Pain Initiative growing and thriving. So what I've highlighted are the challenges we're facing right now. Too much to do and too few resources. I catch myself coming and going pretty much anymore. Developing board ownership and new roles. Again, that whole mindset change of what it is they need to do. It's fine for the new members we have coming on, but for some of those that have been on and were on originally, it's been a bit of a challenge to come on board with that. We do have the flexible program, I think. Identifying and utilizing distinctive competencies. I actually did a competency skills inventory with my board, and I think it's wonderful to have that because now when I need someone with conference planning experience, I know who to go to. When I need someone with legislative and policy experience, I know who to go to. We didn't have that before. Being comfortable with change, boy, that's the only thing we can count on, right, is change. But it can be difficult. And then diversifying our revenues, as I said before, that is just a real challenge for us. We're actually the opposite of what you should be. They say if you've got a nonprofit, you really should be about 85% coming from membership and donor development, and 15 to 20% should be from grants. We're absolutely the opposite of that. So again, just words of caution and invitation that as you're looking at sustainability for your organization, that you tackle that issue. And you're in such a great position because again, we backed into strategic planning. The organization is up and running. I come in, I have to get to the point where they're going to let me come in and do strategic planning with them. And so that we were a couple years down the road before we even did it. You're doing it before you even get out of the starting gate. That is so fabulous. Good for you. So the lessons I learned is money matters. It really does. So let's make sure we plan for that. It does take a team and a lot of skills to be successful, and all those things like communication and organization and planning are very key. Not all personalities are created equal. This is where my master's in counseling psychology comes in very handy. Different people who come into this have very different personality types. The personality types of physicians tend to differ drastically from personality types of social workers and nurses, and so it's interesting to just work with all the different people and the perspectives. And I would just say for myself, having people outside the pain community involved, I think can be a really good thing. Again, I had the opportunity to come in and say, why do you do this? Why don't you do that? Why this? Why that? Because I totally didn't know anything, so I could ask those kinds of questions. So I would welcome you to invite people in like that who really don't have what you would call necessarily vested interest, and trust that they will buy into your mission as I have bought into MOPI's. And that the Alliance of State Pain Initiatives can be a wonderful, wonderful resource, as can other state pain initiatives. So I'll end by saying your dreams can be realized, and good luck to you on your journey. And I wish you well. Thank you.